Hello there, my name is Marcus Hawkins and I'm very grateful to be given this opportunity to share my experience with low carb, healthy fat or ketogenic eating. I work in a solo practice in South Auckland, New Zealand, way down in the South Pacific. It's an urban practice in a large shopping mall in a relatively affluent part of the city. I have one nurse and one receptionist. Here you can see where New Zealand is located. South of Australia, the world's best kept secret. New Zealand, I mean. So why do I advocate low carb, healthy fat or ketogenic eating? Well, there are two really good reasons that have convinced me that LCHF is nutritionally correct. The first one is the fact that the human body has no use for external carbohydrates. It functions perfectly well on fat and protein and has done so for millennia and has evolved to do so. The other fact is that over the last 50 years we've been advised to reduce saturated fats and stop eating eggs since the late 1970s. And this clearly has not worked to make the world a healthier place. At the time of these guidelines there was no contemporary evidence for them. It was only a theory, and strong personalities and influential contacts were able to bring forward these changes. And we have in fact been very good at adopting these new ways of eating, and America has excelled. So now here are some data from New Zealand and our experience with fat reduction. In this chart you can see that in 1977 10% approximately of New Zealanders were overweight or obese. In 2012 this is approaching 30%, and now in 2019 this is over 30%, and we are the third fattest country in the OECD. The theory that in 1977 fat was bad, animal fats and eggs, has not been borne out, and we've seen a rise in obesity, metabolic syndrome, pre-diabetes, diabetes and its complications. And I'd go so far as to label these changes or this effect as white man's disease in the Pacific and Africa and various other parts of the world, where high containing starchy foods were introduced to ethnic minorities or peoples who had not been exposed previously. And what has happened? They have developed the problems that our society has, and not only medical problems but also their morphology has changed as a result of eating different foods and what influence that has had, especially on their facial features. So for the last 30 years I've done exactly as I was told. I've done my best to do what I was taught. I've followed the guidelines for cardiovascular risk, diabetes and tried to manage obesity. But I've not really been getting anywhere until now. And I've now had the best news I've had in over 30 years of medicine, with absolutely no nutrition education to start with. I've subsequently in the last year or two researched and done courses via the Nutrition Network, read extensively around the subject, watched plenty of videos and read a number of books, and now I'm fascinated to be able to improve or reverse significant diseases simply by giving nutritional advice, and I'm absolutely passionate about the subject. So how do I do LCHF or ketogenic eating? Well, I'm doing this myself and I'm a work in progress. I still have some weight to lose. I have diabetes in my family history and I don't want to get diabetes. And there's nothing like doing this for yourself to understand the process. It gives you great insight and can help you give real advice to people. My current regime is to be ketogenic, namely less than 20 grams of carbohydrates a day, and I'm eating one meal a day from Monday to Friday while I'm at work. And for me there's no going back. I think once I get down to my target weight, then I may adopt more of a Mediterranean style diet, but at the moment it's all about LCHF or ketogenic eating. So with my patients, I do this all myself. It's a little time consuming to start with, but it's very rewarding. And I invite people on an opportunistic basis, people who I think will benefit from this way of eating, and ask them directly if they're interested in approaching healthcare through diet, or improving healthcare through diet. I explain the philosophy of LCHF and how it can apply to them, and we come up with some shared objectives. Now I do the same with diabetes, but I'm not going to comment on diabetes here because that is an area in its own right which requires specific advice for both doctors or educators and patients. I give patients a handout with a comprehensive list of what to eat and what not to eat, and I talk this through with them. I recommend watching programs such as The Magic Pill, Fat documentary, Sugar the Bitter Truth, and recommended reading would be The Big Fat Surprise by Nina Teicholz, and these references are included in the handout. So initial measurements and advice include baseline measurements of weight, height and blood pressure. Blood tests include thyroid function, liver function tests, HbA1c and creatinine. We don't measure insulin or C-peptide routinely. This is something the patient would have to pay for, and it may be somewhat controversial in the initial phases of adopting this way of eating. So I ask people to cut down or avoid eating bread, pasta, potatoes, rice, fruit and starchy vegetables. We know that LCHF and ketogenic eating has been shown to provide a balanced diet and includes the micronutrients and sufficient non-starchy vegetables that one requires for adequate or good nutrition. And together with a resource such as dietdoctor.com, which has fantastic educational advice and an ever-expanding knowledge base, this really helps to ensure people are eating in a manner that is appropriate. Monitoring occurs usually on a monthly basis initially with blood tests and measurements. I like to gauge people's carbohydrate intake by asking them about their last 3 meals. And that's quite difficult for them to remember. But it's quite useful as well to give an idea of how much carbohydrates they're actually ingesting. Ongoing advice and support occurs at these visits. Check that people have got a variety of foods to eat and not getting bored. They might want to back off a little bit or increase restriction or even undertake some intermittent fasting if results are not to their satisfaction. We've seen some very pleasing results with improved job satisfaction, and doing something positive is really nice. So now I'd like to share with you some cases. Time constraints mean only the salient facts are given, but the actual course of each patient's management should be evident. So start with 2 young men, both with type 2 diabetes. Now in New Zealand we diagnosed diabetes with 2 HbA1cs over 50 millimoles per mole on 2 consecutive occasions, and pre-diabetes is at a level of 41 to 49 millimoles per mole. So the first case is a 31-year-old male who was known to have pre-diabetes with a normal BMI, and his initial HbA1c when he joined my practice was 112, and literally within a few months, 6 months, he was able to bring that down to 41 just by changing his diet. There's no need for any medication. He's maintained this level, around this level of HbA1c for the last 10 months. The next case was a somewhat obese 31-year-old with an initial HbA1c of 93, and again really in a matter of 4 or 5 months his HbA1c has come down to 49, and he is able to maintain that over the last 7 months. 2 patients have had established type 2 diabetes and have been able to reverse their disease. The first is a 61-year-old male with a BMI of 30.1, having reduced that to 27.8, and his initial HbA1c was 61. He brought that down to 44 within a matter again of just 3 months, and his HbA1c has been maintained for the last 11 months at around that level. The second case is an 82-year-old male whose BMI was not significantly increased. His HbA1c was 81 to start with and fell to 46 again within a few months. He was able to stop his glipizide. However, and it's somewhat amusing, his wife became rather concerned at his weight loss. I'd observed his weight loss and didn't think there was anything too untoward and didn't think we were missing any other medical conditions. But his wife was concerned that she decided to feed him up again and get some more weight on him. And of course his diabetes came back. But since I've seen him recently, he's decided he definitely doesn't want to go back on medication and is going back to his ketogenic or low-carb eating. I've got a 55-year-old male who was able to reduce his insulin and lose some weight. His BMI started at 29.2 and fell to 27.8. His HbA1c from 68 to 63 after just 3 months. He was able to reduce his glargine insulin by 55% and stopped his glycoside, 160 milligrams BD. When I asked him what he thought about the relatively modest fall in his HbA1c, he told me he was ecstatic and was dead set on trying to reduce his insulin requirements further and hopefully get off insulin altogether. This is a 55-year-old male with an initial BMI of 32.7 that fell down to 23.6 in literally 4 months, 16 weeks. He lost 25 kilograms just by eliminating carbohydrates. In the bottom left-hand chart, you can see his liver function test from right to left normalized, and his lipid profile, again from right to left on the lower right-hand box, again has improved with a significant improvement in triglycerides. His HDL had risen significantly, his LDL could now be measured, and his cholesterol to HDL ratio had fallen into a near normal range. And finally, this is a 70-year-old female with an initial BMI of 43.6. She lost 12 kilograms in approximately 4 months, stopped her hypertensive medication of cilazapril 5 milligrams daily, has maintained this weight loss, and as you can see from the bottom chart, her blood pressure is still well within the normal range. So I'd just like to highlight the risks of LCHF or ketogenic eating, and there are not many. Certainly some people have an increase in LDL, but we are not able to measure the subfractions of LDL in New Zealand, and it's generally assumed that the LDL rises because of an increase in the good subfraction. But the benefits are many. Benefits include diabetes improvement or reversal, weight loss, reversal of fatty liver, improved blood pressure control or even reversal, improving bowel function for irritable bowel, for example, or chronic gastroesophageal reflux. The lipid profile, as you've seen, improves. Migraine can improve. Polycystic ovarian syndrome can improve with fertility restored. Resistant epilepsy, the prime reason for ketogenic eating initially, and chronic pain syndromes and chronic fatigue are also said to benefit. So there are a few examples of the way things have improved, but there are many more. And in closing, I've done years of screening, diagnosing and treating, but not much time correcting disease or disease processes. I can now improve the health of selected patients, but it's just by altering nutritional intake, which is new to me as a doctor, and it's nice to make a difference. Taking medication away is not what we do, but we're doing it. And the stressful world of general practice is a lot more bearable, with the low-carb consults actually something to look forward to, and I really enjoy doing and can give very real and rewarding and sustainable results. So the practice of medicine has become rejuvenated with a new skill set and more positivity in the workplace, not just for me, but for the staff around me. Now, not everybody wants to or is able to do this, patient-wise, but enough will make your job more enjoyable. And finally, I have some good news for the cause, and that I was recently published in the General Practitioners with a General Practitioner's commentary on the low carbohydrate healthy fat eating in the Journal of Primary Healthcare. So I'd like to thank you for listening, and goodbye from Aotearoa, land of the long white cloud and Lord of the Rings.